Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to the Back in Action podcast, a podcast about strength and conditioning, spine health, and rehab, a podcast for athletes who have been training for a long time, athletes who are new to the game, and athletes who just want something new. With me today, Dr. John Lavelle, Coach Dusty Holden. Today we're talking about disc degeneration and radiculopathy, and I'd like to start, Dusty, with you, if I can interrupt your coffee time. How many athletes do you see that come to you with a diagnosis of disc degeneration? How common is that?
All.
Yeah, most of them.
Okay.
Yeah.
Okay.
It's high.
And they know that, or we know that discs degenerate over time? I come to you and I have been diagnosed with disc degeneration.
No, I'd say that's probably more like 50-50.
Okay.
Because I don't feel like you're having that. He's not very, I would say, big on handing out diagnoses and things like that where people can attach themselves to a certain thing. So it's probably lower in the fact that they walk in ahead of time already predetermined.
I feel like that's intentional.
100%.
Yeah, I feel like that's intentional. You're, and correct me if I'm wrong, you're not giving them that appeal to authority, and you're not kicking them in the teeth first day in.
Right, well then they're going to carry it with them forever. So the worst thing to say is you have degenerative disc disease. One, it's not a disease. There is a degenerative component to it that happens with age, but it's also not necessarily because you're older you have it. There's other factors that go into it, but when you give them a diagnosis, they're going to carry that forward forever. I mean, so many patients come in and say, well, I'm here for my back because I have an L4-5 disc bulge. And I'm like, well, you actually can't feel that L4-5 disc bulge and tell me that's right where the pain's coming from. So people just start to identify with it, and then they carry that forward forever. And that's what I don't want, because we've talked ad nauseum about, fear avoidance being, fear of injury and movement because someone told you had a disc degeneration. That's going to get us down the wrong path. We want to forget that you have anything with your back and get you moving and living. So that's why similar if I do an injection, I never say the word needle when I'm doing the procedure, because they're just going to hear needle and freak out. So same thing with a lot of these diagnoses. Now I do give them a diagnosis. You have to for billing purpose, but I don't emphasize that.
I feel like that is incredibly rare in today's day and age, first and foremost. And I feel like we race to want a diagnosis first off.
Right.
And then we race to give it because that's how you get reviews a lot of times, right? It's, they found this, like it's some sort of shocking finding. And then you've actually, what you're saying is we set them up for failure by rushing to that diagnosis.
A lot of things I see in the spine, I just explain as these are quote unquote normal changes that most people are going to see over time, but that's limiting you from doing this. It's preventing you from doing that. And that's what we're treating their functional standpoint versus what's going on in their spine.
Let's go back, and we talk about this maybe every podcast, and I think it's good to always review because we're not doing this as much as what you are. But tell me, what is the disc? What does the disc do? Why do I need to be concerned with the health of the spine?
Yeah, so in our spine we have the vertebrae, and we kind of talked about this in one of the early episodes, but you have the bony vertebrae, and that's there to protect the spinal nerves, the spinal cord, and then the nerves at the base of the spine and the low back. And that's all created so we can protect what controls our body. So the spine is just an extension of our brain, and that's what's controlling all our function and activity. So you have a bony structure to protect that spine. And in between each vertebrae is a cushion, basically. You can think of it like that, which is the disc. Okay. And that provides some movement within the disc in multi-directions. So rotation, bending, twisting, lateral, all different planes of motion.
And the disc is made of what?
Yeah, so the disc is made of, you have these about 20-25 outer rings of the disc, and that's called the annulus fibrosus, and it can contain annular fibrosis, and it contains the nucleus pulposus in between. So you have these collagen fibers which make out this outer rings. Okay. And like I said, there's about 20-25 of them or so, and then inside is this nucleus, which is about 80% water, and then a protein that provides almost like a mesh-like substance in there, almost like a Brillo pad in between. So it's softer, more cushiony. And that's where all makes up that disc that provides some kind of, people call it shock absorption, but also it's there for movement.
Okay. So now, so first and foremost, you have what would you call it normative? Would you call it healthy that doesn't have degeneration? Like,
yeah, if you're 10 years old, you probably you'll see a nice healthy spine. But
okay.
I've seen teenagers and then on up all get degeneration of spine. It's just part of life. We don't live forever, so our cells start to die off, so you have less maintenance and regeneration of tissue, so those discs start to degenerate.
So is the medical cause then age or genetics or prior injury or?
All the above.
Okay.
So as we get older, we're all going to get degeneration. There's almost no one you'll see on an MRI that's 30 or over where I couldn't show you some level of disc desiccation, we call it, some breakdown of the disc. But some people that are 50 have beautiful looking spines where you could be 20 and have a horrible looking spine. So why is that? That's obviously has nothing, is independent of age, the severity of that disc degeneration. So maybe they had an injury, but that's rare that I see someone come in with disc problems because of an injury. It's genetics plays a factor too. A lot of it is movement and nutrition.
Explain that.
So if you're having a lot of inflammation, that's going to, as we've talked about, is going to break down cells more quicker.
Okay.
So you're going to have less, antioxidants in your food to fight off. If you're eating poorly, less antioxidants and anti-inflammatory molecules in your food. If you're eating, fast food, processed foods, you're going to get more inflammation, and that's going to decrease blood flow and decrease healing within the cells, so your mitochondria won't be as healthy, which helps with cell turnover. So that's going to all cause degeneration more quickly in the spine.
And that's from lack of movement?
That's from poor nutrition.
Poor nutrition.
And then the movement piece is if you're not keeping your muscles strong and flexible, those muscles work like cables holding up the spine. Like I always say, like cables holding up a telephone pole. And you want those cables doing the work on your spine, which is your back muscles and other accessory muscles. And as those muscles weaken, you get more pressure on the spine, so it's going to wear away more quickly.
So what would be my first sign that something like that is happening?
You're going to start, maybe being a little stiff in the morning, or, it's basically stiffness.
Okay.
That kind of first sign.
In the
maybe
morning,
a little achy discomfort after you're moving.
Okay. So in the morning, though, we're automatically a little bit more stiff because the spine will hydrate, right?
Correct.
So it would be over and above that.
Correct.
Okay. What would be a way to test that? Is there a way to test that? Would you check standing toe touch?
Exactly.
Okay.
So usually with the discs, when the discs are becoming symptomatic, you're limited in some of your flexion, because when you flex forward, that puts more pressure on the anterior aspect of the disc, and you can get some bulging backwards or irritation of the line, those rings in the disc where they bulge a little bit and stretch along where the nerves are. The nerves that monitor the discs are on the posterior part of the disc, called the sinovertebral nerve, and that can get irritated and cause some pain. So usually it's with, a bending or a bend and twist, that type of activity. So,
Dusty, we've seen, I think we might be strong, but there are 1,000-pound deadlifters out there.
Yeah.
So if humanity can lift 1,000 pounds and we supposedly go from something that would be perfection to lesser than, wouldn't we still be able to deadlift? Wouldn't we still have the potential to be able to deadlift more than what we do, even if there's a degeneration in there?
Yes.
So if that's the case, then how do we consider that? I guess I'm trying to talk. Degeneration just keeps sounding bad.
Right. And
so I'm trying to see how that's what I'm saying.
And the biggest thing is, I guess, to understand is that you can't stop it, but you can slow it down.
Correct.
And the way you would slow it down would be through strength training.
Sure. And if we're capable as people, the biggest deadlift is 1,000 pounds, and all of a sudden, I can't do that anymore. Could I still deadlift 900 with disc degeneration? You see what I'm saying?
Yeah.
Isn't that sort of strange that we put that moniker on it and then we don't do that? And if that's the case, if we stop hinging and we stop moving because it takes us away from a potential that we may never even get to, then why do we label it that? I guess that's what I'm asking. Is that too philosophical of a question?
No.
Or
why do we label it disc degeneration?
Yeah, I mean, if it's just normal, isn't it just, if it's just a normal thing, why does it have
It's more putting it's not a disease. So disc degenerative
but it is
disease,
referred to as
a degeneration.
Yeah, that's where it's garbage. It is not a disease.
Okay.
So that's where the labeling comes in and is wrong. It's just like saying low back pain is your diagnosis. That's a symptom of something going on. So low back pain is a garbage diagnosis too. Degenerative disc disease is garbage, but disc degeneration is just like wrinkles. So you can name your skin do get wrinkles. That doesn't mean you should never look at yourself in the mirror because you're going to be disgusted, Same with the disc. You should still use it even though it's degenerating. It can still function and do its role. So you can still bend and lift if you're strengthening around it. That degenerative change will happen slowly in the background over time and hopefully never cause the symptom of low back pain.
Dusty, how do you deal with that when somebody comes to you and they say the exact opposite in terms of, I've been told never to bend, lift, and twist ever again?
His first reaction is you should never go back to that doctor.
Well, that'd be the first thing is who told you that.
Okay.
And I never want to like talk bad about
Don't talk bad about other professions.
Exactly. But you just want to try to more or less help them understand like what you're actually saying.
What is the first course of action for somebody who doesn't get to work with Dr. Lavelle that has heard the horror stories of bend, lift, and twisting? What's the first thing that you're going to tell somebody like that?
Well, it's not going to be so much as what I tell, but as much as I just listen, and so that they're heard. Because I think that's really important. Because I'm never going to get to the point where I actually get to tell them something if I don't make them feel like that I'm listening and hearing what they're saying. So if they've got a concern with hinging, that's maybe where they're feeling a lot of intense pain, or I would say most of the time that's where they initially felt the pain to begin with. So they've associated that as the tipping point, that trigger point, that this is where it began. And I was bending over to pick up whatever.
Sure.
So it's just helping them kind of back up, and then let's work through just building confidence back into that movement that you can do this. And maybe right now you're not able to do it at the same level, or the same range of motion. Maybe if you were training, and you were lifting 900 pounds, well, we may not be there now, but the goal is to get you back to, where it is that you want to be doing whatever it is that you want to do. So I think it's, again, just listening first and then helping them reconstruct, this movement pattern. It could be the squat in this circumstance we're talking about, the hinging. I just think people get so scared, and then they typically deal with that for, who knows, sometimes years, before they actually ever go in and see a doctor. Yeah. And then it's kind of a coin toss on maybe what they're told. And I would say a lot of times they're told, it's easier to just say, hey, don't do that, than to do what we're talking about in dialoguing and listening, and then really trying to walk somebody back through, because to me, when you tell me you don't want to do something, that becomes like, it's the focus point for me now, I'm going to get you back doing that thing.
Yeah.
And that's going to be really what I focus on. So this other stuff now becomes kind of secondary, because I know this is a big barrier it's going to be in our way until we are able to get through it. So
deal with it.
I mean, we can tiptoe, around for a little bit if that's what it takes to help them, get comfortable. And I do that, whatever it takes to help somebody get comfortable and get them to a point where they're moving and believing in themselves and believing that they can do it and trusting me. But ultimately, I got one thing on my mind, and it's like, I'm going to get you through that, that barrier that's stopping you, because it's really, depending on how long they've been dealing with it, I mean, it has really had a huge impact and a negative impact on their life. Sure. It's relationally and financially, and I mean, it gets bad.
Yeah. And if someone's been told, you have disc degeneration causing a disc bulge or causing a disc herniation that's hitting the nerve and radiculopathy, and if they're told by a clinician, never lift, never bend, never deadlift, never squat. That physician is just trying to treat their symptom of pain, and it's going to be short term. They're not treating their quality of life and their function long term. So yes, they'll look good in the short term, because if you limit some movements, and as we always talk about, take those movements out of their life, yeah, they'll feel good in the short term, but what are they going to be mentally,
long-term,
physically, long term?
Huge.
How do you limit any of those motions and live a life? So that's why I say, honestly, you got to find a different physician who's going to teach you and show you how you can get back to those movements versus taking them away.
I think that's a big thing too, is like you don't, if it's all subtraction, then that's a big red flag, and maybe you got to subtract a little bit in the beginning to just calm things down. But ultimately our goal is addition. Like, we want to get you back by doing more and progressing. That's what we do. So
what you said and what you guys share that's so well that I continue to point out is that the assessment is the workout. The listening to somebody is the workout. And that alone, I believe it's called the Therapeutic Alliance, automatically reduces the symptoms just to be heard. So maybe one of the red flags is, like you said, if you go somewhere and immediately the assessment is 2 seconds long and it's, oh, this hurts, just don't do this. That might be the very first red flag. Nobody listens.
Don't play, don't work.
Right. Because it should be, what do you want to do? And I want to do this. And then it should be, here's how to get back to that. Maybe something like, don't deadlift wrong, but we still need to deadlift.
Yeah.
Okay. Yeah, that's exactly right.
I mean, because I would imagine that there is a very high percentage of our listeners who they probably aren't deadlifting. One.
And to be clear, deadlifting is just picking stuff up. We keep saying deadlift.
It's just hinging at the hip.
That's right.
So that's a deadlift.
Right. Yep.
They either aren't doing it, or I would say then there's another large group that they're doing it, but they're very, very scared. So it's something that they don't do a lot or enough of. And there's some, who knows where along the line, there's been a bad either experience or association with the movement, and that's kind of, kept them from going there. And it may just be lack of information from a training standpoint, that they just don't feel like I can't do it correctly. So if I can't do it correctly, I'm just going to not do it.
Right.
I mean, we're in gyms every single day, and we can see. I mean, at one of our gyms, we have a huge area that is specifically for deadlifting, and it's probably one of the usage, it's one of the lower usage areas in the facility.
Yeah,
so
that's true.
And we're in a facility that is very, I would say, strength training heavy, like specific. Lots of folks are doing
more barbells than cardio equipment
for sure. Yep. So, if that's what we're seeing in our facility, then, I mean, you can only imagine in just kind of the run-of-the-mill facilities that it's just not even happening.
Yeah, and you said earlier that disc degeneration leads to it, and then you named a couple of other things. So that again, so the disc degeneration, I have to deal with other things, or is that in and of itself the thing that's going to prevent me from doing what Dusty's talking about?
As discs degenerate, so as early as teenage years, you'll start to see dehydration in the disc. So where they're starting to lose some of that fluid. As I said, it's about 80% or so water in there with proteoglycans, proteins intermixed.
So when you say dehydration, does that have to do with just hydration in general?
100%. I think so.
Yeah.
So that's where the nutrition piece comes in.
Yeah.
For sure. But that's the first thing you see. So on an MRI, these discs will have these black outer rings I spoke of in an inner white kind of nucleus.
Okay. And
that white will start to turn gray teenage years, 20s, 30s, and onwards. And that's that first part of that disc degeneration. And then you'll also, these outer rings I spoke of, they start to kind of stretch. So you'll see, as these outer rings, as I said, there's, some studies have shown 20 to 30 of these rings, as they start to tear and stretch, you get disc bulging.
Okay.
So that's this kind of the second part you'll see, or I often will see on MRI, of this kind of cascade of degeneration. Sometimes those rings can tear enough where some of that inner nucleus will bulge to the periphery. and that's called a bigger disc bulge, or depending on the shape of it, it could be called a disc protrusion, a disc herniation, a disc extrusion. And so people always ask me, well, you said disc bulge, but I was told I have a disc herniation. It's all under this umbrella of just degeneration. Whether you call it an extruded disc, a protruded disc, or a disc bulge is just based on the shape of how it's moved into the canal.
Good to know.
It's none is really scarier than another. Those are kind of the things you'll often treat. One is you just see some disc desiccation, or you're getting a little disc bulge that can cause discogenic pain, where you don't have pain down the leg, but just pain in the back with hinging usually, because that disc is bulging enough, and when you bend forward, it bulges a little bit more and pushes against the nerve back there to cause that discogenic pain.
Is this the lower back band pain, or is this the single side, this one piece hurts
It
pain?
varies. If it's bulging more to the right, it may be a little more to the right side, but
So
that's where you got to differentiate. Is more arthritic strain causing that band to cross, which we've talked about in the past, that facet arthritis, or is it more discogenic pain?
Is there a time in my life, meaning I'm 30, I'm 40, I'm 50, that my percentage dramatically increases for disc degeneration, that I'll feel the symptoms?
I would say as you get older, it's more likely, but I usually see more severe radicular symptoms, kind of that middle age, 40s to 60s.
And is there a lifestyle habit that leads to that more than another? And that
the lack of a lifestyle habit, or just sitting.
Okay, gotcha. Lots of
being sedentary.
Yeah, got
for
it.
sure. So we've looked at studies. There's a study in 2018. I don't have it off the top of my head who the author was, but compared people that were more sedentary versus athletes. And people that are more physically active have less degeneration in their spine than those that are more sedentary. So that's a pretty powerful study, and that's been replicated over a few years, where the more active you are, the more strength training you're doing, because as I spoke about in the beginning, the stronger those muscles are, that's going to stabilize that spine. You're going to degenerate less quickly. So you're going to be less at risk of getting disc protrusions and disc herniations, and if those are big enough or just in the right spot in the spine, and it can hit the nerve coming out of the spine, which I said the spine was there to protect. But if you have some of that material bulging into where those nerves travel through, it can hit the nerve or just cause inflammation around the nerve and pain down the leg, which everyone likes to call sciatic pain. It's not really the sciatic nerve, but radicular pain down that leg. And that can be miserable. I mean, people say it's worse. Women say all the time it's worse than childbirth when that pain is rip-roaring down that leg because of that disc degeneration.
Okay. Now, is there too late if I'm 50, it never worked out before?
No.
So if I'm 50 and I'm in pain, if I started working out? Are you going to jump
to do a deadlift? Probably not.
Okay.
And that's where I think a lot of clinicians get scared to recommend kind of hinging or deadlift. You don't want to, if you're having disc pain or pain hitting the nerve down the leg, you don't want to just go tomorrow and do a deadlift, because I said that hinging does bulge it further. So it can, if that nerve is rip roaring down that leg, you don't want to just keep irritating it. But you do want to start strengthening and moving, so you can start doing some hinging without weight, which
so
you're
done
awesome
correctly, even if I'm 50, 55, if I started today, I'm going to see a benefit from that.
100%.
I'm not lost.
You have to do it, or it's just going to get more frequent during the time. But those people also on MRI, it's not just the disc we got to look at. So we can't just see a report and say disc herniation at L4-5 towards the right, hitting the L5 nerve, causing leg pain due to the L5 radiculopathy. What else is going on there? Probably their multifidus is not even present because it's atrophy, which was talked about before.
Okay.
That muscle atrophy. So I want to point out to them why they need to start strengthening the back. So maybe it's not starting with a deadlift, but it's doing glute bridges. It's doing some back extension to stabilize those extensors, doing some accessory work, and that's going to build you up so you can start lifting off the ground.
So that's what I was going to ask you, Dusty. So they get that I'm 55, I'm 60, I'm whatever, never done anything before. Dr. Lavelle says we need to go work out. Where do you start them? If we've already talked about the hinging is the thing that's probably going to make it worse right out of the gate. How do I build them up to doing the functional thing?
Well, the first thing we're going to do is assess the hinge pattern. Okay. So we're just going to potentially back them up against the wall and move them out, a few inches from the wall, and just start with
you're checking to see if they even hinge.
Yeah, and also just movement pattern. Is it a hinge or is it a bend?
Or a squat. So if I'm somebody who's been protecting, I'm just going to shoot my knees out. I don't even have a clue what hinging is.
I mean, those are easy. We see things like that. Those are real quick, easy adjustments that we can make. And honestly, they're going to experience relief and success in just correcting.
Yeah.
So we don't have to put any weight in anyone's hand.
Hinge when you're supposed to hinge, squat when you're supposed
and
to
so
squat.
if that's the case, and maybe it's only, we're 2 inches off the wall, and now my hinge pattern is, very limited, but I'm starting to introduce that hip hinge. From there, it's going to be about just trying to increase the range of motion. And in one session,
From top down.
Yeah,
Okay.
we could maybe start to go to where we're trying to get the fingertips to the top of the knee, and then it's fingertips below the knee. And so from there, it's let's see where do we start? Do we feel pain at a certain spot versus another? So then we might back up, and then we're going to spend some time, in that range of motion that's available, in maybe building some strength there. But again, I think a big part of it is still on that confidence side, because you're showing them that you can do this. But
What's a movement that you like that if I could not hinge, that would build confidence for me to be able to hinge?
I would go to the ground and probably lie on the back and introduce the glute bridge.
Yeah. Okay. Feedback and still hitting posterior chain. So if I was an athlete who's never done this before, maybe something I could try would be on the ground glute bridges, bilateral glute bridges, unilateral glute bridges, both.
Yep.
Okay.
And so you're getting a hip hinge, but you also only to a certain degree.
And it's non-threatening.
Non-threatening. Okay. You're on your back. There's no weight involved, and you feel in control.
Is there another step up from that? So let's say that I got my glute bridges. What would be something that's a little bit more progressing towards the hinge? It doesn't need to look like the hinge, but something again that's building confidence.
Well, I would also like from that position, maybe it's a leg raise. Like a single leg raise where we've got the knee is extended and locked out.
So we've worked posterior chain. Now we're starting to work the anterior, so via the hip flexor, which is often weak because of sitting, like you talked about.
Yep.
Okay.
And then, from there, we're probably going to come up from the ground and to a standing position. And that's where the next thing would be is like, all right, let's see what we do have available. And that's probably where we would go to the wall hinge. And it could be holding, a broom, PVC. Again, that's more for just
feedback.
Yeah, feedback, activation. And then from there now, just in a very short time, we've introduced 3 different movements that involve a lot of different muscles. And now that person who's kind of been, locked up and paralyzed, so to speak, they're moving.
That's right.
And they're training.
That's right.
And so we're starting to make progress, and you'll immediately start to see
symptoms will go down right away.
Yeah, that central nervous system, it just you can almost see it.
That's right.
Unwinding.
And this is where I think a good place we talked about last week with carries is a good place to introduce moving some weight, but not necessarily doing the hinge yet, but you're going to be strengthening those glutes, hip stabilizers, posterior chain by just doing a farmer's carry.
And it's also a point too where that at 3, we had 3 movements there. At the next point, I might shift completely off of the hinge now, and let's look at the squat.
Sure.
And kind of go maybe a little bit of a different direction, but also it's in a movement that involves a lot of joints.
Favorable movement leads to confidence for unfavorable movement, for sure.
Yep. And so now it kind of, psychologically, you feel like, okay, we're not doing the thing that's threatening anymore.
And it's successful. Like if you're a good squatter, great. Let's squat.
Exactly.
Yeah, that's right.
And the squat is universally scalable, just like what we talked about.
That's right.
So lots of different, variation, ranges of motions, and types of squats that you can do. And, that when I feel like when you can start stacking, the movements, then you're winning, and it's just going to, it starts to get momentum, and you just kind of start building and building. And before you know it, an hour's went by, the person's sweating, their heart rate's elevated, and they're smiling. And so, it's like, that's a good day. And so now it just comes down to like, all right, we got to win. Now we need to stack those wins and just keep progressing them. And you'll just notice every session from that point on, you just continue to build momentum and build momentum.
And what's so powerful about that is we're kind of just talking about movement patterns here and muscle movement. But like you just said, they're smiling, they're sweating. So you're increasing dopamine release in their brain. So you're getting rid of that fear avoidance because they're no longer associating it with a horrible movement I should never do. But, oh, this was kind of fun and I hinged. It's extremely powerful doing it that way versus retracting thing or scaring patients away from doing stuff.
Now, is the reason that I would have the nerve compression from the disc degeneration, or is that just one of the things that a disc degeneration could cause? Segmenting into our next section.
Yeah, so as that disc degenerates, rarely do you get nerve compression.
Okay.
So sometimes you can get a large disc herniation where it's going to be right against that nerve and compressed it to the bone in front of it. And that can cause axonal damage, and you can develop weakness, foot drop in that leg, loss of sensation, loss of proprioception, where if it's in the low back, they may not be able to lift up their toes or ankle.
Tell me the best time after saying that to come see you. Like, what's the red flag to, man, tomorrow, you set that appointment now.
If they're noticing weakness.
Okay.
That's when
so if I got the stiffness that we talked about, maybe not.
No.
But if I have that
if you have motor dysfunction, so
okay.
loss of muscle strength, that's when I want to see you and assess and probably get an image to see how bad it is. Usually, even if you have weakness, it's going to improve. It's rarely, like I said, due to a true compression that is a surgical emergency. I would almost never have a surgical emergency in the back. Sometimes higher up in the spine, if it's causing bowel and bladder incontinence, that's called cauda equina syndrome.
How often does that
I've
happen?
had 1 in 12 years.
Okay.
And I see thousands of patients a year.
Okay, got it.
So almost never.
Okay, got it.
But the biggest thing is if your weakness, we should make sure it's going to improve and how we can improve it. But that's rare. Usually it's from a disc bulging, or if you want to call it a herniation. And usually it's not from compression of the nerve. It's because it's causing that space where that nerve to travels out. So as we talked about in the beginning, this spinal vertebral column is there to provide a tube basically for the nerves to go down. So it's a contained space. Mm-hmm. So if that disc pushes into that space, that's going to narrow that space where the nerves are traveling through, and it can cause irritation. Usually it's based on movement. So that's why if they hinge initially and that disc moves a little more into that space, it causes more narrowing to irritate that nerve. But it's not constantly being compressed. It's just certain movement patterns. If they're still trying to swing a golf club with all that velocity and keep twisting, it may just repetitively irritate that nerve, so that nerve starts firing more frequently. Mm-hmm. It's rarely a true compression of that nerve. It's usually a narrowing, and that nerve gets irritated based on movement patterns. That's why a lot of patients will say, well, I'm okay. If I'm sitting, the leg doesn't bother me. But when I get up or do any bending and twisting, that's when it bothers them. It's because it's just that movement is causing more narrowing around that nerve.
For somebody who's never experienced that, what does that pain feel like? Not where I can't actually move my foot or I get a foot drop or something. Like, what does the pain feel like?
Sometimes it's an electrical shooting down the leg, or a sharp stabbing pain shooting all the way down the leg.
And is it, like you said, is it just when I that's when I do it, when I actually lean over, or is it just a constant sort of electricity?
It can be constant.
Okay. So there might not be a single thing that I do that I feel it on. It could just be a daily thing where it comes and goes.
Correct.
Okay.
Sometimes it's not even the nerve getting hit. It's just you've had an acute tear in the disc, or that bulge happened, with a trauma or something you did, and it causes a lot of inflammation. That's called radiculitis, where those inflammatory processes irritate that nerve. Okay. So it may not be that there's much narrowing there or anything contacting the nerve. It's just the inflammation causing that.
This is somebody who too might come up and be like, man, it just feels like I need to stretch. And that's not really what we want athletes to do. We really don't want them stretching or trying to stretch a nerve. We want them to move the body to help alleviate the discomfort. Am I correct?
Correct.
So is this where you would introduce something like a glide? Like a little bit of a floss, per se? Mm-hmm. Okay, so that would be good. Good. What other movements?
Explain that. What do you do with a nerve floss or nerve glide?
So what you're trying to do is, if you imagine the nerve tunnel, you would be moving essentially the body around it, as opposed to locking down one side and then trying to lengthen the nerve. Not that you necessarily could, but I think that the trying often is the case that you'll just make it irritated.
So what movement would you do?
So if we could describe it, I would sit down on on something higher that my feet would be hanging. And then I would extend at the knee, pull my toe back towards my face, and lift my head towards the ceiling, and then reverse all of that. So I take it all down and then take it all back. So instead of trying to stretch the nerve from both ends, I'm trying to shift it in the tunnel to get rid of that compression. And I would call that some sort of a nerve glide or nerve floss.
Well, you could also, CARS.
Yeah, controlled articular rotation. So that's the
Say that slower.
Controlled articular rotation.
So, I mean, that you can do that shoulder, any joint.
And anywhere.
Exactly.
And
so,
anywhere. That's right.
And lots of good, movement in the hip, which could have a really big impact on the back.
And that's one thing that we recommend to a lot of our athletes is controlled articular rotations every day. CARS. In PE back in when we were 5, they were joint circles. And it's a fancy term for joint circles. Now, of course, you can do pretty much every joint that you have. The spine obviously likes to flex and extend a lot, but you can rotate a lot from the T-spine. A lot of people, and just since we're kind of talking about that, what that looks like, you'll almost always hear, I feel cricking and cracking and snaps and all these things. As long as there's not pain associated, that's probably a good thing. And you're probably busting some
tendons,
stuff up. Right.
For sure.
That could be just hydrogen. Crepitus is one of the terms for it, but a lot of times that doesn't mean stop. And then if we are at home and we're trying a little bit of a controller articulate, like if you find a sticky spot, just go around the sticky spot, take inventory, do it every single solitary day for 2 weeks and see if the hip moves better or the shoulder moves better. And talk about cheap and easy. If you've been sitting down for an hour, just get up and do one. Like super, super easy. Now, when you see stuff like that, what are other movements that are good for somebody that has that nerve pain that's running down the leg, that's in pain right now?
So what everyone loves to do, a lot of, trainers or therapists, they love the McKenzie protocol, which is good. It's definitely a good tool. And a lot of times the McKenzie protocol is just where you're assessing freedom of motion on body, whether it's flexion or extension. And a lot of times, as we mentioned, with discs that are hitting the nerve, they like to flex. It's hard to flex. So they'll do a lot of extension-based exercises. So that's what it gets thought of as McKenzie's extension. It's not,
like a
but that's usually the tool
and so forth. Yeah. Okay.
However, when you have pain down the leg, as I said, when you have a contained space and the disc is bulging backwards, there's these joints back there called the facet joints. And so if the disc bulge is a little bit to the right or to a little bit of the left, it can cause narrowing right between those facet joints and the disc, so really causing narrowing around the nerve. And when you lean back, that space is even more narrow. So you're going to cause radiculopathy by doing that constant extension. So it drives me crazy because almost always, less so now with therapists that know me, that for my patients, but they would often start with extension. And even if they had a disc bulge but no radicular symptoms, I come in and said, well, now you're having leg pain. What have you been doing with therapy? Well, I'm doing 100 press-ups a day. Well, now what I just spoke of, sometimes movement causes that nerve to get irritated because it's in a narrow space. That's what they've induced is radiculopathy because they keep extending.
And it's excessive.
Yeah.
So this would be another good time, like we talked about, for carries that are promoting more of a neutral spine with movement. Maybe cat-cows, but maybe not forcing an end-range position.
Yeah.
Maybe loading, so you get that sort of sponge metabolic waste effect where you're actually getting rid of some of that inflammation just by movement pattern. Is that kind of what you're talking about?
Yeah.
That would be the preferable, or is it just something as simple as, like Dusty said, here's A, we regress it to A. Cool, A worked really well. Can we do B? Now
I just can't stand when it's, here's what we're going to do this all the time, do this
It's
at
one
home.
way.
But you also have to have variety. Like you were saying, we'll get the hinge, but then maybe we'll back off of that next time and work more on the squat.
And this
You
talks
need
a
that
lot about somebody
diversification.
like pressing. Like if I went to you, you're like, man, my back is whatever it is. And then 4 movements later, you're like, oh, we're going to do a press. Somebody's like, well, why are we pressing?
Yeah, I came here for my back.
Yeah, that's exactly right. We hear that all the time. When that's not really, of course, our first thing is to get you out of pain.
Yeah.
But getting you out of pain may be doing a whole bunch of things that don't look like exactly why you came here.
And that's where the insurance, if you're in the insurance model, that can be hard because if you're sent to someone for your low back, they can only bill for treating that low back. Well, you can be creative because if you're doing a press, you can activate the lat, which attaches to the low back. So you could still do it.
Oh, for sure.
But that just doesn't happen.
For sure. Yeah. What are most common misconceptions that you find or that you, Dusty, find when it comes to disc degeneration or any sort of nerve compression?
I can't bend. I'm not allowed to bend or squat.
Not allowed, right? Yeah. I shouldn't do it because I'm going to break.
It's just, how do you live? Yep. Tell me a movement where you're not squatting or hinging.
Yeah.
Laying flat in bed, I guess.
I would say that's the biggest one. And I think that's where people get in the most trouble is when they have back pain, they stop moving. And I totally get it. Just a few weeks ago, my back kind of like locked up on me, and immediately the tendency is to like shut it down,
100%.
because it is scary. Your back, when your back is bothering you, it's a scary thing. So, but the biggest.
Well, let me explain that, because what were we doing when that happened? We were doing deadlifts. His back locked up, so something happened. But did you finish the deadlift set? He was. I never seen him kind of wince, and he was doing that.
And technically, I couldn't identify anything that like went wrong. Sure. So it's like, how did this happen? Sure. I was doing the same thing that I always do, but today it just hit differently.
I slowed down
in
terms of warm-up weight. Was it?
Yeah, 185 pounds.
So not even close to, because you're a fantastic.
No, not even half. Yeah, not even 50%.
Which is almost always when it happens.
A little bit higher rate or a higher rep, so a little bit more volume. But it wasn't even like at the beginning. It was midway through. So I'd probably already, done 30 to 40 reps at that point.
Sure.
And it locked up on me. I stopped. I walked around, but more like just to like you said, take an inventory, like trying to figure out, because in the beginning, I didn't know exactly where it was hurt. Because it was kind of just global across my low back. But then in a few minutes, I immediately went to the ground. I did some foam rolling, did some glute bridges. And the more I moved, then the more I started to figure out, like, oh, this is actually in my glute. So it was like glute med. So that was it's probably 15 minutes. I think by the time our workout ended and he left, I had told him like, hey, it's not in my back. It's actually in my glute.
Yeah, high glute.
But initially, like, I didn't know, and I'm pretty confident had I just shut it down, it would have been like this long, process, because my back did tighten. Like everything kind of tightened up.
Which could be a signal to move on to something else, but definitely not necessarily a signal to stop things. And in fact, the lack of confidence that you get later really can keep going for weeks.
And even, within 2 days, I'd say I was 80%. And in like 3 days, I was almost back to 100. Now, probably about a week later, I hopped back on the barbell at the same weight that and here's the deal. There's no doubt that it was in my mind. Like, I was very intentional when I pulled that weight.
Sure.
But I had to get back there.
Right. When that immediate injury or the insult happens, not even an injury, you reassess. You reassure yourself by doing movement, and then you redirect.
Yeah. Yep. I'm 2 weeks later now, and I don't have it's back to normal.
Right. And that most often is the case.
And so, but I think a lot of that though was due to the fact that I just didn't stop. Had I stopped and just rest, it would have prolonged.
Oh, for sure.
The injury for weeks. And I'd say that's the other thing. Is people, your natural tendency when you get hurt or you're in pain is to stop. And it's that begins this downhill spiral. And you've got to like snap out of that. It's okay. I would say 24 hours and you got to get a game plan.
And to be 100%. Clear, we're not saying just keep punching yourself.
No, it's not about, nobody said, go back and do the thing,
Right.
But it's important that you get back up and that you're moving at least in a forward direction. You're not sitting stagnant or even going back. And that 24 hours, like after that,
Yep.
you got to get back, get the game plan, and get moving, because otherwise you're going to prolong it and turn it into, it could be weeks, months, and even years if it's not, met head on.
100%. Well, and our nerves have a memory, so you're going to get into that muscle spindle firing. They're going to keep firing abnormally. Then that muscle, if it is more muscular, will stay tight.
Yep.
And then you get the brain involved with fear avoidance and increasing that negative loop where it does become
And when
chronic.
the brain gets involved,
Then it's
dangerous.
That's right. So, gentlemen, what I'm hearing is no matter the diagnosis that comes back, be it nerves running down the leg, be it the back is tight or just stiff or in pain, the worst thing I can do is stop moving. The first thing I need to do is start moving.
Yes.
And the way with this degeneration, yes, it's going to happen to all of us, but we can slow it down. There's going to be varying degrees of that degeneration, whether you're moving and keeping the back strong, whether you're keeping hydrated with proper nutrition. That's all going to slow that rate of that degenerative process in all the cells of our body. So it applies to our back degeneration. And when things do come up, it's the same treatment. You got to get strong. You got to strengthen that back. We can prevent these flare-ups from happening if you keep it strong, but if they do, we got to look at where the deficits are in your muscle strength and why that's happening and start to engage those muscles and strengthen it back up. But just because you have a disc bulge or disc protrusion, that's not staying with you for life. Yes, the disc bulge, it doesn't go back. So if someone tells you you have a disc protrusion, we can get that to go back in, that just doesn't happen. You can't change gray hairs and wrinkles, and as cells die off, they do. Same with disc bulges. That's going to be there forever, but we got to treat the nervous system and the muscles around it, and that's going to prevent you from surgery, constant injections, opioid medications, and I mean, we've seen it with thousands. It definitely makes a difference.
Yeah.
I'm a little sad that we can't change the wrinkles and the gray hair, but I'll take the getting stronger. Gentlemen, thank you for your time.
Appreciate it.
Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.